It's become conventional to start one's surgical presentation with a picture of your glittering high-tech steel and glass hospital. So I like to start my lecture about mistakes with this slide, which shows my hospital in London in the background with a conveniently placed cemetery in front of it. Because what I want to talk about is the problem of failure in medicine, which is a hugely important problem and one which perhaps isn't discussed enough. The great French surgeon Lourdes, who was responsible, you may remember, for describing the Lourdes syndrome of claudication of the internal iliac arteries, had this wonderful phrase he wrote in his book, The Philosophy of Surgery, which he published in the 1950s. Every surgeon carries within himself a small cemetery to which he must go from time to time to contemplate. It is a place full of bitterness and regret, a place where he must look for an explanation for his failures. It's also put very nicely by Atul Gawande in one of his books, the one called Complications, where he says the problem is not about stopping bad doctors, but of stopping good doctors from making mistakes. The problem is we all make mistakes, we're human beings. But in medicine, particularly in my speciality of brain surgery, the consequences of our mistakes for our patients can be so terrible that it's very easy to deny them to oneself, let alone to the patient and the family. And yet, we learn most in life from mistakes. And if we don't recognize our mistakes, we won't learn from them. So there's a problem of honesty about things going badly, both with oneself and with one's colleagues and with one's patients, is immensely important. In medical legal terms, of course, there are two types of mistake. There are what are called errors of clinical judgment. It was a difficult case. In retrospect, I can see I was wrong, but I thought carefully about it. And then one's not considered to have been careless or negligent. But I'm more interested in talking about carelessness, malpractice, negligence, where we tend to think if a doctor makes a careless mistake, he's a bad doctor. We make a moral judgment. But as I hope to discuss, the problem is it is normal and natural for us as human beings to make mistakes. As an example of a mistake of the first type, which perhaps wasn't a mistake, as a young woman who was admitted to my accident and emergency department unconscious with fixed dilated pupils, so clearly very ill. She was put on a ventilator. And my colleague who was responsible for the case, it wasn't my case, wasn't sure what the scan showed, although the patient was clearly very, very poorly and was unlikely to do well. And he said, well, we don't know, we don't know what the scan shows, and therefore we don't have a definite diagnosis, therefore we have to operate. And although he said also, because she's in a deep coma and with fixed dilated pupils, she's very unlikely to make a good recovery. So they did operate, and did the operation called a decompressive craniectomy, an operation I have considerable reservations about for different reasons anyway. And you can see from the brain scan that the front part of the skull has been removed, so the swollen brain can swell out. Now, looking at the scan later, I knew what the diagnosis was because I'd seen this case before, a similar case. It's not that I'm a better doctor, I'm just a bit more experienced. And I was pretty sure the scan showed a diffuse infiltrating tumor called gliomatosis cerebri. And this indeed proved to be the case, and she survived. She did not die, which she would have done very quickly if she'd not had the operation. But she had suffered one of the terrible complications of raised intracranial pressure, which is the posterior cerebral arteries both infarcted. And as a result, she was now cortically blind, as well as with a fatal diagnosis of gliomatosis. So for all I know, she may have died by now. But in a sense, the point of the story is this. I met the family subsequently, though she wasn't my patient. And they said, no, we're really very grateful for everything you're trying to do. So my perspective, I would have almost certainly, if I'd been involved at the beginning, would have said it's best to let her die now rather than operate. My perspective was, in a sense, quite different from the patient's family. And it is this huge problem we face, particularly in brain surgery, as to what is the value of a life? What is the value of quality of life? Is it better to die slowly, cortically blind, but with your family, or to die suddenly. Who knows? And yet we face problems like this and questions like this very often in brain surgery. An example of carelessness on my part, a fairly light-hearted case, because the patient didn't come to serious harm. I had 3 discectomy operations to do for sciatica. One patient had pain down the left leg, the other 2 had pain down the right leg. It was in the private hospital, so I did all the consenting. Well, I'd do the consenting myself anyway. But I saw the patients myself, wrote down on the consent form what I was going to do, went down to the operating theatre, and the computers broke down. So I had no scans. And I became quite convinced that all 3 cases were right-sided. It's called the anchoring effect. Because the first 2 cases were right-sided, I assumed incorrectly the 3rd case was on the right side when in fact it was on the left side. But ironically enough, it was such a large herniated disc fragment that I was able to remove it unknowingly from the wrong side, and the patient woke up, the sciatica had gone. So it was fine, even though I'd done the right thing for the wrong reasons. But then I was rung that night by the nurses who said, well, the patient's fine. I mean, she says the leg pain's gone, but the other leg, the leg which was fine before the operation, she's now got some tingling and pins and needles in it. So I spoke to the patient on the phone and tried to persuade her that she had misremembered which leg the pain went down. I mean, in retrospect, ridiculous. But she said, no, I had sciatica down the left leg. The right leg was fine, but now it's a bit tingly. And I was saying, well, if you operate on a trapped nerve, often the leg is a bit tingly and numb afterwards. But she wouldn't accept this, although she was quite friendly about it. So I felt obliged to get out of bed and go up to the hospital, look at the operating note, or rather the consent note, the consent form, and there I'd written in my own handwriting, left side. So I'd completely not just misremembered it, but then I did what's called the confirmation bias. I reinforced that by trying to persuade her she was wrong. It was ridiculous, but it shows how easy it is to make these mistakes, how unreliable memory is, and how we often try to reinforce our mistakes with further mistakes. I mean, the story ended happily, she was pain-free, the other leg got better. But it was a warning to me about how easy it is to make these mistakes. And then there was another case of a young woman who tried germinal neuralgia. Again, I consented her myself, but I'd got muddled. I was confusing her with another patient, and I consented her for the similar but not the same operation for hemifacial spasm, where you get terrible twitching of the face rather than pain. And because when I got the consent, I talked about spasms, she obviously assumed I meant pain. And I then operated, in effect, on the wrong cranial nerve. And after the operation, I went to see her. The operation, I thought, had gone okay. Well, I was a little bit uncertain about what I'd found at surgery. And she said she was no better. And then it gradually dawned on me that actually I'd operated on the wrong cranial nerve. Fortunately, she forgave me and I reoperated next day and it all went fine. But we are on a very narrow, tightrope. It was interesting that when and even checklists would not have got around that particular problem. So it's a paradox of experience, certainly in my case, but you learn to trust yourself less in a way, and you become a little bit more open-minded, you check things more carefully, because you think of all these absurd, careless mistakes you've made over the years. It reminds me a little bit of a tragic story of Korean Airlines, where they had a very high crash rate in the 1980s, and it culminated eventually in the crash of a 747 on the island of Guam in the Pacific. And the black box was in bad conditions, low visibility, rain and cloud, and obviously the pilot thought he was higher than he was. And the black box tape recorder, you can hear the co-pilot saying to the pilot, 100 meters, 70 meters, 50 meters, 20 meters, and then they're all dead. And the upshot of this was that Korean Airlines realized the problem was the co-pilot would not dare to tell his pilot. They were too low. Or he thought, well, the pilot must be right and maybe the altimeter's wrong. So they had to retrain all their air crew to to have a much less deferential attitude, because it was said traditionally in Korean society it was very hierarchical, and in effect a co-pilot would rather die than tell his boss, actually boss, we're going to crash. And in fact with standard aircrew training for all airlines nowadays to have it, I can't remember the phrase, but the crew all can talk to each other as equals even though the captain is in charge. And although I get a bit irritated by all the aviation analogies with medicine and surgery, because flying an airplane is not like doing an operation. Patients are not like passengers. Nevertheless, there is a lot to be learnt from it. It was curious that I was a bit unhappy about the WHO checklist when it was introduced, and a lot of it is rather unnecessary. But I realized in retrospect my resistance to it was I didn't like to think I might be wrong. When I went into the operating theatre, I wanted to be confident, in charge, trusting myself. And to be then asked lots of questions suggesting I might be wrong or operating on the wrong side would make me uncomfortable and unhappy. And I've overcome that now. I'm perfectly happy with checklists, but they are only a start. And just as you say, no castle is stronger than the soldiers defending it. No checklist is stronger than the staff filling it up. It's only the beginning of a process of trying to improve patient safety. While I was preparing this, writing my book about my mistakes and other things, I came across this wonderful book by Kahneman, the great psychologist, who got the Nobel Prize for Economics, because he showed that with his late colleague Amos Tversky, that we are much less rational than we think we are. We are particularly bad at estimating risk and probability and other people's qualities. And these, of course, are all immensely important factors in the practice of surgery. If you say to a patient, you need an operation, we are in effect saying, these are the risks of surgery, these are the risks of not operating, therefore you should have the operation. But these are all questions of judgment. Risks of surgery means risks of surgery in my hands. How many of these operations have I done? Do I really remember the complications? Is the case in front of me now really similar to the ones I'm comparing it with in the past? And a judgment like that, as Kahneman has shown, is subject to all sorts of mistakes and biases. And the same in terms of the risks of not operating. How well do I know the natural history of the disease if it's not treated? Again, a question of judgment. And looking back on my career, looking at my worst mistakes, they were almost all to do with decision making. There is this huge misapprehension in the public at large that the good surgery is all about steady hands. It's not about steady hands. It's about good decision making. If an operation goes badly, it's almost certainly because you didn't calculate the risks involved properly beforehand. You didn't understand the case properly. Not that you did the wrong thing or your hand slipped or something like that. So Kahneman and Tversky did work on what psychologists call cognitive biases. Cognitive simply means thinking. We're often biased consistently in the way we think about risk and probability. And the analogy Kahneman uses at the beginning of his great work is the Muller-Lyer optical illusion. However hard you look at those two horizontal lines, they'll always look different lengths, even though actually they're the same length. Our brain is hardwired, the occipital cortex, the visual analyzing areas are hardwired to see those lines as being of different length simply because of the different arrowheads. And there are many similar biases and distortions we make when we're thinking about the problems of probability and risk and qualities. And there's a long list of them. Some of them here have confirmation effect, the halo effect, hindsight bias, risky shift, things like that. And a lot of these apply to the practice of surgery. And when I was depressing myself, trying to remember all my worst mistakes, I'd lie in bed in the morning, sort of lucid dreaming, remembering all the bad episodes in my surgical career. And in neurosurgery, there are many of them. And the more I thought about it, the more I remembered. And it really became very depressing. I also found if I didn't write them down immediately, I forgot them all over again. And one of these very important biases is what Kahneman calls the availability heuristic. A heuristic simply means a rule of thumb, and it basically, we remember things that we estimate the probability of something happening in the future based on our memory of similar events in the past. And our memory of what happened in the past will be influenced more by the emotional consequences of that event rather than by the probability. So as a surgeon, if your last case of something or other went very badly, when you're faced by a similar problem again, you will almost certainly overestimate the risk next time round. Ditto, and I'll give an illustration in a moment, if you've done this operation many times and never had a serious problem before, you're very prone to underestimate the risk of something going wrong or appreciating something has gone wrong after the operation. So the availability heuristic is hugely important in surgery. And then there's a framing effect. The way information is presented to us will strongly influence the way we respond. Kahneman and Tversky came up with this classic little game, you could call it, to show this. And this was a question they showed mainly to medical professionals, infectious disease doctors, epidemiologists, public health people, smart people like you or I. And they said, an outbreak of an unusual Asian disease is expected to kill 600 people. Assume that the exact scientific estimates of the consequences of two different programs to combat it are as follows. And you have a choice between a certainty and a gamble. The certainty is that if you put program A into effect, 200 people will be saved. If you put program B into effect, there's only a 1/3 chance everybody will be saved, but there's a 2/3 chance everybody will die, nobody will be saved. And faced by this rather difficult choice between a certainty and a gamble, almost everybody goes for option A. Well, it's better, we'd better not gamble, we'll go for the certainty of saving 200 people. And then you ask people, well, let's have a different problem. With program A, 400 people will die for sure. With program B, there's a 1/3 chance nobody will die, although there is a 2/3 chance 600 will die. And then almost everybody swaps over to option B, even though actually they're exactly the same options. All you've done is the first iteration, you say option A, 200 people will be saved, and the second iteration, option A, 400 people will die. So the way information is presented, the use of words like live, die, life, death, will greatly influence our decisions when we think we're making a rational assessment of the problem. And as an example of the way I discovered from reading Kahneman's book, it gave me a sort of toolkit with which to understand and analyze egregious, careless mistakes I had made. This was an operation, it's a simple operation for a benign malformation at the base of the brain. It's an operation I'd done many, many times without any serious complications. The commonest problem is a mild aseptic meningitis afterwards due to spinal fluid seeping in and out of the neck muscles, because it involves an incision at the back of the neck. And this is I did the operation went very well. She went home unusually quickly. To make matters worse, my colleague was doing a similar operation in the next door theatre to mine. We're good friends, but his operation was going rather badly, and I felt very pleased. I thought, I've done a really, really neat operation. But then a week later, the patient's husband rang me up to say that she was unwell. It was on my mobile phone. I was actually at work in the hospital on a Sunday morning, so I was preoccupied about other things. And he said, well, she's in bed, she's feeling a bit rough. Those are the very words he used. I remember it all very clearly. And I made the terrible mistake of assuming, without thinking, quickly as, it's probably aseptic meningitis, that's what's happened before. And I prescribed steroids and said, well, come back and see me if she's not better. And they came up to see me 2 days later, and she was actually desperately ill. It was only at the end of the conversation, I remembered this later. He said, what about the fact the wound's leaking? Now, if it actually, I'm not blaming him, but if it said at the beginning of the phone conversation, my wife's wound is leaking, I would have said, bring her up to hospital immediately to see me, because that is evidence of something going seriously wrong. But I jumped to conclusions, my optimism bias, the operation, the availability heuristic, the framing effect, that was a phone call which I wouldn't normally receive. I didn't expect mobile phone calls to carry very sinister information. So she came to terrible harm. She survived. She had serious infection, in fact terribly rare, as a streptococcal subdural empyema, which I've never seen before or since. And even then I was so biased, in a sense, in my own favour, and my judgment distorted by the availability of heuristic, I couldn't even look at the brain scan properly. Looking at that now, it's obvious that the cerebellum is herniating out. There is low density pus around the brainstem. But I looked at that and didn't see it because of my cognitive biases. And then there's a halo effect, which is a tendency to like or dislike everything about a person. This is a problem we all face as senior surgeons. We train doctors, we have an ethical responsibility to the patient in front of us, but we also have an ethical responsibility to our trainees' future patients. And in many ways, the two duties are incompatible. And I like training. I like to think I'm a good trainer and popular. Over the years, I've usually liked my trainees very much, both from America and in England. But I realized when going back on this sort of professional post-mortem that some of the serious mistakes where patients had come to harm was where I'd left the juniors to do too much of an operation. I'd overestimated their ability because I liked them. I think in recent years I got better at knowing when to intervene, how much to supervise. But if you supervise every step a trainee surgeon makes, he or she won't learn very much. And to get the balance right between letting them operate more or less independently and close supervision is very difficult. And there's a list of patients who came to serious harm because of this mistake on my part. We say in English there are no bad soldiers, only bad officers. And on the whole, with very few exceptions, I think that applies to the training of young doctors. So what did I conclude as a result of thinking about all my mistakes? And the one or two examples I've shown is only a very small corner of my inner cemetery. Well, trainees are dangerous. It's an unfortunate fact, but true. And careful, wise supervision and setting an example is a hugely important part of being a senior doctor. I also discovered that actually, when I was a young consultant, I'd be very worried sometimes about major operations I had to do, and I couldn't sleep, and then I'd get really agitated. And I then came to realize that when I was operating, if I was underslept, I hated operating, all the pleasure of operating went. But I was so careful, I didn't trust myself, that actually the operations from the patient's point of view went fine. And then I realized it wasn't a problem, and I soon learned I slept perfectly well. But self-confident, well-slept surgeons can in many ways do more harm than underslept ones. It's a cognitive bias I describe myself called the confidence effect, showing off. It is said that Wertheim, who came to London, I think at the end of the 19th century, to demonstrate his abdominal hysterectomy, didn't just tie off one ureter, which is the main serious complication of the operation, but tied both ureters off. And I can think of 2 or 3 operations I did where I had an admiring audience of overseas visitors watching me, and I made some really very silly mistakes because I wasn't concentrating, and perhaps I trusted myself too much. So to get the balance right between the self-confidence you need as a surgeon, but also the self-criticism is again a challenge. I also learned over the years that on the whole long complicated operations are bad operations. The best operations are simple operations. And I also learned in recent years there's a lot to be said for operating with colleagues who are equal to you. So you're not supervising them. And if you have a very, very big brain tumor that's going to take all day, it is less tiring, more enjoyable and safer for the patient if you actually operate as a team. And there is a place for checklists, even though, as I said, it's only the beginning of trying to solve the problem of patient safety and the fact that so much of what goes on in hospitals is so complicated and there is so much room for error. How can we reduce this problem of cognitive biases, this inbuilt tendency to make mistakes? Well, Kahneman puts it this way: recognize you're in a cognitive minefield, slow down, but more doubt is the last thing you want when you're in a minefield. The upshot is that it is much easier to identify a minefield when you observe others wandering into it than when you're in it yourself. So what this means, in effect, is that other people are better at seeing my mistakes than I am. So the crucial conclusion I reached to my self-analysis and surgical self-analysis was it's really very important to be a good colleague and have good colleagues. The problem with this is that this means meetings, and meetings easily become a huge bore and a great burden, and of course are very much against the surgical ethos of wanting to get on and do things. Surgeons are temperamentally, we are not suited to meetings. And to organise meetings well so you have good relationships between the doctors is a great art and very important. So Kahneman says this as well. He says there's much to be done to improve decision making. One example out of many is the remarkable absence of systematic training for the essential skill of conducting efficient meetings. In my experience, so many medical meetings are deeply inefficient. Lourdes Moynihan was a famous surgeon at the early years of the 20th century. And he once said, I think he was quoting an earlier writer, what are the qualities required of a surgeon? And he said, well, nerves of steel, heart of a lion, hands of a woman. I don't know if you get away with that nowadays. But I would say, no, I don't think there's, well, yes, up to a point, Lourdes Moynihan, but having good colleagues is very important. Being a good colleague is very important. When I see the difference between good surgical departments and bad surgical departments, or healthcare systems, the good ones are where people cooperate and get on together. Yes, there's a certain amount of healthy competition. But if it's all vicious rivalry and argument, as I've seen on many occasions, this is bad for patients, it's bad for training. I wrote this book. It came out 2 years ago. I didn't really think very much about why I was writing it. I just wrote it. And to my surprise, it's been remarkably successful. It's sold, I believe, so far 250,000 copies in England alone. There are 22 translations, either published or in preparation. It's been a bestseller in America, Denmark, Spain, Germany, England, etc., etc. And although it celebrates some of the wonderful things about being a neurosurgeon and doctor, there's a lot about failure in it, along the lines I've been discussing earlier. And in retrospect, looking back on the book and its remarkable success, it is both a confession in the sense of trying to be honest about how difficult medicine can be and how we do make mistakes and have to live with that. It's also a celebration of the immense privilege of being a doctor. And there are many ways of making the world a better place. Medicine's only one of them. But I've always regarded being a doctor as an immense privilege, although at times a very painful one. And the other point in the book is mistakes happen. Medicine is never going to be a precise, predictable business. It's not like running a factory. It's not like running a business. There's something profoundly different about it. And it's uncertainty. So much of what we do is about uncertainty. We don't know for sure what's going to happen. You're juggling one probability against another, and you have fearful, frightened, anxious patients for whom you're looking after. So the doctor-patient relationship is a phrase which has rather dropped out of use in recent years. It's a very real thing, and it's all about trust in the face of uncertainty and danger. And it's not just a smokescreen for professional self-interest, as some people have argued it is. So I'd summarize all that by saying to be a good doctor is very difficult. I've worked all over the world in very advanced countries like America and very backward countries like Iraq and Sudan and Nepal. And if you strip away all the technology, all the glittering stuff you have in the States, and to the very, very primitive conditions many of my colleagues work in elsewhere in the world, the problems we face as doctors are actually identical. The technology is almost like sort of dazzling. It's not exactly irrelevant because it does help patients and outcomes. But the first problem is finding that balance between compassion and professional detachment. One chapter in my book is about my son who had a brain tumor and almost died when he was very young. Fortunately, he's alive and well many years later, thanks to the surgeon who operated on him. But if I felt for all my patients as a surgeon myself, as I did for my son when I watched him go through a series of terrible operations, I couldn't do the work. So we have to be detached, but we mustn't lose our compassion in the process. And that actually is very difficult. Likewise, to be a surgeon, particularly if you do dangerous surgery, you need a certain element of heroic individualism. But as I said, you also need to be good at team working. Your colleagues are better at seeing your mistakes than you are. How well the operation goes depends on the pre-op workup, on the post-op care, how well you get on with the theatre nurses, the ICU nurses and colleagues. So although the word team working has become horribly devalued by its abuse, particularly in the National Health Service in England, it is nevertheless very important. But you still need a heroic individual as well. Psychologists talk of the risky shift, whereby a group of people will make more dangerous decisions than an individual. And for the patient to have one person who is individually responsible for you is still very important, although increasingly difficult to achieve in modern medical systems. You need to be very self-confident to operate, to be a doctor. You need to be very self-critical as well. And here again, it's a constant balancing act. And if you decide to operate in a difficult case, are you being brave or are you being reckless? And if you advise against surgery and say it's best to let nature take its course, are you being a coward or are you being wise? Again, a very difficult balance to strike. Patients need hope as well as good technical treatment. Many of them are going to die despite our best efforts. So again, to find the balance between being realistic and honest with the patient and their family, but not depriving them of hope, being optimistic but not over-optimistic, again is very difficult and a great challenge. And you have to find a balance between egotism. Are you a doctor to make money? Because all doctors are paid well. Or are you there bleeding heart to save the suffering of the world? Again, it's a balance to be struck. And then in the modern world, there's this thing called the work-life balance, which didn't really apply to me when I was in training 40 years ago. It was all work and no life. I liked that, but I don't think my family did. So these problems apply to us all doctors, at whatever level of skill and technology we're working at. And they're all very difficult, and they're pretty unique in many ways to the practice of medicine. And when we get it wrong, patients come to harm. Osler, the great physician and writer, who was Harvey Cushing's great hero, wrote, "Medicine is a science of uncertainty and an art of probability." I used to be very irritated by people, doctors, saying, "Oh, the art and science of medicine." I thought it was all very pompous. But if you see it as stated by Osler, I think it's very apposite and very true. What we are doing is we're using science to try to help our patients. But despite that, it is often very uncertain and very difficult. And I think it's very important in the modern day and age, where medicine is becoming so expensive and we come under more and more regulatory pressures and managerial pressures, we must stand up and say, look, what we're doing is not easy, it's difficult, and it's always going to be difficult, and it's full of uncertainty.